Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsberg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
38-year-old former smoker with stage 3B, poorly differentiated adeno in the right lung. PD-L1 is negative, no targetable EGFR mutations. Progression is despite, he had gotten 2 cycles of cispem, but progressed on that, then went on to bilobectomies, right upper and lower and middle lobes. Lymph node dissection, pericardial resection, and path extending, carcinoma extending to the medial margin and the phrenic margin, superior pericardial fat in the phrenic margin. Cough, dyspnea, weight loss over 2 months. Performance status is 1. No other medical history, though imaging shows severe emphysema, and smoking history as noted. We'll look at the imaging, and obviously this is preoperative.
We see that there's a large mass in the right middle lobe, which measures up to 10.8 cm. And it's very FDG avid, as you could see, with some central necrosis. The mass is causing mass effect on the right atrium, and you could see it displacing the heart to the left. In addition to that, there is right hilar lymphadenopathy, which measured up to, we don't have it on these images, but it did measure up to a centimeter. And that was also hypermetabolic. And there's also a small subcarinal lymph node, which we see on the PET image on the bottom left, which is avid. We also see that in the lungs, there is emphysema, severe emphysema with small centrilobular emphysematous changes.
Okay. So to summarize the diagnostic workup, we have the imaging, brain MRI was done, post-operative or post-neoadjuvant progression after 2 cycles that led to going straight to surgery, and pathology that we reviewed. No actionable mutations, PD-L1 is 0. And so we have pathology summarized, poorly differentiated, solid, this one also with sarcomatoid features, 1 out of 3 subcarinal nodes positive, and staging is YPT4N2M0 with the positive margins. And basically the question is about adjuvant chemo and radiation. I would say, Ram, if I could start with you, systemic therapy recommendations. I think that at least is in 2021 less of an open question than the radiation component.
Sure. So as we heard, this patient has positive margins. Is that right?
Yes.
So this patient still has residual disease. This is an R1 surgical resection. And the patient did not respond to a pemetrexed-based therapy. Now, given that the patient has sarcomatoid features, I'm not too surprised that the patient did not respond to chemo and more so to pemetrexed-based chemotherapy. At this point, I would say a different chemotherapy regimen, perhaps a taxane-based chemotherapy would be more appropriate. I also know that the patient is going to need radiation. So this may be a situation where we have a conversation about what is more urgent, and in this case, with the persistent disease, perhaps going to radiation first, and then using a carboplatin paclitaxel kind of regimen for 3 or 4 cycles as adjuvant therapy would be, in my mind, a reasonable approach.
What about a concurrent approach? He's 38 years old. He has a pretty challenging overall cancer, that hasn't responded to good systemic therapy. I mean, cispem would, I would say, be what many of us consider the best choice that you could come up with for systemic therapy for an adeno.
No, absolutely. I did think about the concurrent chemoradiation setting in this situation. The reason I felt it would be better to finish the radiation and go to full dose of chemotherapy is for the simple reason that with the concurrent chemo-RT, we were going to have to compromise on the dose of chemotherapy this patient is going to get for systemic control. So chemo in that situation may help with radiosensitization, but not as much as providing a good systemic anti-cancer effect.
Cliff, what are your thoughts here? I mean, we have the LungArt trial that challenges the role of postoperative radiation therapy, but hasn't been published. It's a heterogeneous population. And if there's anyone you would want to maybe treat individualized, it's a 38-year-old who progressed through good first-line systemic therapy or neoadjuvant.
Yeah, I agree. I think if this patient had a surprise N2 alone and none of the other kind of stacking of risk factors, then I think one could make a pretty compelling argument to do systemic therapy alone without post-op radiation, based on the results, albeit not fully published, but pretty compelling from the LungArt trial. And just to be clear, that's a randomized trial that demonstrated in a relatively modern radiotherapy treatment, not the way we do things today, but still mostly modern compared to, say, the initial port trials, that there's a reduction in recurrence with use of post-op radiation, but no clear reduction no clear improvement in survival. In this patient, though, they have frankly positive margins. They have a high-risk histology. They're a young patient. I think this is somebody where they, in the absence of anything else, they will recur. And it's unclear even with what we can offer them whether we'll change that metric, but it seems worth trying.
How do you get behind the idea of sequencing and concurrent? I mean, I would just propose, and I would like to come up with some kind of recommendation for him, perhaps concurrent followed by additional chemo. And again, that would depend on how he's doing clinically, but a 38-year-old basically pull out all the stops. I mean, you can't overtreat this guy. At least it's not the same as a 77-year-old with a poor performance status.
I think it's a reasonable thing to consider. We have a slightly older trial, but we've looked at this specifically in a prospective trial that showed that it's at least doable to give concurrent. It does increase toxicity, so I think a lot of it would have to do with how they're healing, and then actually having a frank consideration with the surgeon in terms of how they did the repair and what this is something you really want to talk to the surgeon, get an understanding of how that surgery went, what their indications were for kind of optimal post-operative wound healing as well.
So Ram, can I just clarify, what's your, I mean, we can just say it really depends on how he's doing, but your level of enthusiasm for concurrent versus sequential here, just because
I'm certainly open to that, Jack. One minor point, I would want to make sure that the patient has had good imaging studies at the present time point to make sure that the progression did not have other sites outside the areas that we have focused on in our conversation.
That's great. I mean, the last thing you'd want to do is go all in locally if he already has adrenal metastases. So. Okay, so if I will just summarize by saying that for this patient with a challenging situation of progressing through neoadjuvant and an R1 resection with for a T4 tumor, we would definitely recommend radiation, despite the ambiguity of the data out there, but with the positive margin and the unfavorable factors, and also in a 38-year-old, we'd want to lean toward favoring that rather than withholding. We would be tempted to favor also a concurrent approach if that's possible, recognizing that chemo did not do that much on its own and maybe could do more as a radiosensitizer. Would consider chemo radiation, even possibly followed by some additional chemo, depending on how he's doing clinically. We need to monitor that. And we would also strongly favor good imaging that is current to clarify that we don't already have more advanced disease before focusing on entirely on managing the chest.